Dan Crenshaw is the Executive Director of the KC Healthcare Collaborative. And as the Executive Director, he brings together diverse stakeholders to drive healthcare innovation, improve population health, and promote health equity in the Kansas City region. The son of a nurse, Dan grew up witnessing firsthand the significance of compassion and equitable patient care. Today, he continues that tradition by advocating for equal access to healthcare for Black and brown families, ensuring everyone has the opportunity to receive the whole person care that they need and deserve. Prior to his current role, Dan spent a decade as an educator, followed by 2 decades in the legal profession, where he distinguished himself as a litigator, leader, and advocate for diversity, equity, and inclusion. His dedication and commitment to the progress and implementation of diversity and inclusion earned him several awards, including the Missouri Lawyers Media's Diversity and Inclusion Award and the Greater Kansas City Chamber's Bernard Powell Award for demonstrating outstanding leadership, a deep commitment to service, and a passion for improving the Greater Kansas City area. Additionally, Dan serves as a member of the Supreme Court of Missouri's Commission on Racial and Ethnic Fairness. The commission's goal is to examine and review current practices and to recommend measures to ensure fairness, impartiality, equal access, and full participation for racial and ethnic minorities in the judicial process and in the practice of law. Dan received his undergraduate degree in philosophy from Princeton University and earned his JD from the University of Kansas. So please join me in welcoming Dan Crenshaw. And it's a different... I think he has different slides. These are my closing. I'll turn that over to you.
Ooh, thank you very much. Well, good morning, everyone. Oh, we can do better than that. I know it is before 9 o'clock, so I'm at it. So let's try that again. Good morning, everyone. There it is. That's what we like to see. Well, I want to thank you all for being here. Thank you for having me. My name's Dan Crenshaw, and here's where I'm going to begin with. First, I am an attorney, and I hope you will not hold that against me, but that means I'm going to talk faster than I should, but it's just how God made me, so I'm not trying to trick you into anything. And it also means that I'm not used to getting up this early in the morning, so I want to apologize. I'm going to get revved up. We're at sea. I need that alarm too. So I'm excited to be here. So as they mentioned, I'm the Executive Director of KC Health Collaborative. We are a multi-sector collaborative based in Kansas City, Missouri, but working with the 6 county regions in the Kansas City metro, and our goal is to advance health equity. And so what I want to talk about is what we are doing through collaboration to advance health equity that I think can be translated and transferred into rural communities as well. And so the title of my presentation is what Dr. King quoted. One of his comments was, we may have come over in different ships, but we're all in the same boat now. So there's this idea that as we start thinking about how to advance health equity, how to take care of our neighbors who are receiving the least, who deserve the most, how do we work together to make that happen? So I'm excited to be here. So here's what the plan is going to be. We are going to talk about collaboration in action. I'll talk a little bit about what KC Health Collaborative does. I'm going to talk about collaboration in action that's focused on one demographic, which is the Beehive in Kansas City, Missouri, that's focused on unhoused folks. We're also going to look at Thrive Allen County, which is a collaborative action focused on taking care of the folks in the Allen County region. And then we're going to talk about the Learning in Action Network that we've created in Kansas City, Missouri, dealing with region-wide collaboration around recognizing and addressing racial bias in the healthcare system. And then we're going to have an exercise at the end of that. So it's my hope that you'll be able to take something away from all of those experiences, get a sense of how those folks work, bless you by the way, how that work can be translated into your own communities. And then I hope to be a resource for you as you move ahead in your own work. One of the things we talked about at dinner last night is I want this to be as interactive. We had talked about doing some Mentimeters and doing some electronic interface, and that's just a whole lot of work and a whole lot of stress. And all that was going to happen is that the KFMC folks were going to be stressed out. Is it going to work? Can we get the... So you should feel free to raise your hand and ask a question. We're going to do old school Oprah. We were happy to interrupt. Because at the end of the day, and I love me some Tammy Elliott, but she didn't tell me till after I committed that we're going to be together for 90 minutes. So that means we're either going to get along really well or you're going to be like, get him off the stage. So let's go ahead and keep that thing going. So with that, Look at that. Here's what we're going to do. Here are our objectives. And I'm going to walk around a little bit because I do like my little Oprah. I like my Oprah feel. So we're going to talk about the difference between cooperation and collaboration. Sometimes people will get that confused. We're not going to spend a lot of time talking about that, but we do want to make sure that folks have it in their mind about what we're trying to get accomplished. We're going to talk about those successful collaborations that I mentioned. I think there's some key takeaways that will apply to all of our work and I think will be beneficial. And then we'll talk about potential partners and resources, which I think most of you have. Tammy and her team already have that going as well. I'm going to try to keep an eye on time too. So there's our difference right there. So when you think about collaboration and when we go through the examples, collaboration really is about working with others to achieve shared goals. I think sometimes, and not in this group, as a lawyer, I will tell you, people love to cooperate because lawyers will always say, well, my project is the most important. But I also think, in my experience in the 17 months I've been on this job, it's also clear that in the nonprofit sector, there are folks who are spending a lot of time cooperating rather than collaborating. I've got my mission statement, I've got my goals, I've got my funding stream. If you want to work with me to help me get that grant, that'd be great, but the grant's got to be under my name. And so what we want to be thinking about today is how do we pursue collaborative opportunities? And so we can, and I just mixed those up, didn't I? I said cooperate, collaborate. So y'all got to help me out. So collaboration is working towards your goals. Cooperation is working towards your own goals. So what we want to be thinking about is collaboration and moving forward with collective impact. That is how we are going to make change in the healthcare space that we're operating in right now. And it's also going to be the only way, in my mind, that you're going to be able to address social drivers of health. Because at the end of the day, social drivers of health, and I've been around long enough and sat on enough boards, that phrase is pretty fancy right now, but if you talked about this 10, 15, 20 years ago, these were just issues that killed people because they lived in the wrong zip code, they lived in the wrong part of the state, they were the wrong sexual identity. There's a long list of things. And so and all of that is going to be handled at the policy level. And we just can't wait for that to happen. We need to be thinking, what can we do tomorrow morning to make changes for our communities? And so I'll talk a little bit about KC Health Collaborative because this is what happens when you get a nonprofit person a microphone. We're going to do a little sales job. So KC Health Collaborative was incubated in 2015. With the idea that we want to address issues like health equity that no one organization can do on their own. We were incubated by Blue Cross Blue Shield of Kansas City, Missouri. They sat around and got together and said, we need to do something. Now, between us, because we're all family, we know that they did that in order to cut costs. They were concerned as they looked around at the community that there were some folks that they would call frequent flyers who kept coming back and using services. And they wanted to think about how do we address that. Over the course of several years, they invited more people to come back to that table and have conversations about how do we address this? How do we make this better? But at the beginning, it was about the triple aim. It was about better care, healthier people, smarter spending. And so there you get a sense of our multi-sector membership. The upside is, and this is where we'll give Blue Cross Blue Shield credit, is they recognize that no one's going to listen to an insurance company if they start making recommendations. And so they expanded this table to bring employers, they brought community-based organizations, they brought hospitals, they brought other insurance plans as well, and you've got a sense of, and this is a brand new deck, so we're going to be updating this, but it gives you a sense of all the different kinds of folks who are sitting around the table having conversations about how do we make healthcare better for all of us, for every person, not just the folks who are commercially insured, not just for the folks who are on Medicaid, but for everyone. And here's what we do. We are really excited about our community table. Our community table allows us to bring all those different voices to kind of smooth some of the rough edges, because we recognize that insurance companies need to make money. We don't have a problem with that. We don't object to you making some money, but we don't want you making money on the backs of the most vulnerable members of our community. And so we want there to be an understanding that you need to be providing behavioral health to all of your folks. And you need to be supporting critical care hospitals who are taking care of those folks, even if they don't have insurance. right? I know. Thank you for the clap, because here's the other thing, because lawyers, we're used to a little bit of, not much applause because we're lawyers, but in this nonprofit space, they do that finger clap, that whole thing. Anyway, it's a lot. It's a lot. So I put the quote up there because what I was impressed with, that is from one of my board members. And on the spot, we asked him, what do you think we should be doing? What should our focus? And so it was sort of gratifying to know that you've got people sitting around the table in a leadership position who understand the assignment. They understand what we're trying to get done. So how do we do it? In short, what we wanted to do is to raise the profile of health equity. So when you think about what influencers do, they sit around and they talk about the shoes and the clothes and the makeup. I don't think enough people, and y'all probably agree, not enough people understand what health equity is and why it matters and why it's relevant. So something as corny as a consistent LinkedIn presence and Instagram, and I invite all of you to follow us on KC Health Collaborative, allows us to create a more powerful narrative about what health equity means and why everyone is invested in the advancement of that work. This is not just a black and brown issue. This is not just a poor issue. This is everyone should be invested in this. So as an example, one of the highest rated posts we had was about race, ethnicity, and language data, and that no one kind of understands what that means and why it's important. And every hospital wants to talk about how successful they are taking care of folks, but when they disaggregate the data, they then recognize that they're not taking care of folks from certain zip codes, they're not taking good care of their black and brown folks, that the outcomes are disparate. And so we equated that with Jay-Z. Jay-Z won a Lifetime Award, the Grammys, a couple of years ago. I don't know how you get a Lifetime Award at 40, but that's a separate conversation. I mean, he's good, but he spent all of his time talking about the fact that his wife had never gotten Album of the Year. And when the Grammy folks were castigated about that, they indicated that they did not know if there was bias in the selection process because they don't know who sits on their committees. They don't know the race or the ethnicity or the gender of the folks who sits on their committee. So there's an example of the failure to understand your own data means that you can't make the changes. So you can't say there's no bias, because seriously, how is Beyonce not getting Album of the Year? So that was an example where people could understand REL data when you equated it to sort of current events. So that has worked out really well. We're getting good feedback from that. The other thing we're seeking to do is to create a source of data that policymakers can rely on. Because right now, if anybody has spent time in Kansas City, Missouri, you know that all we talk about are 3-peat chiefs, we talk about a downtown baseball stadium, and we talk about FIFA World Cup. We aren't talking about affordable housing. We aren't talking about transportation. We aren't talking about, the only transportation we talk about is our new streetcar that runs north and south and takes very good care of the tourists who come into town, but it does not move it east and west, taking care of the folks who have to work. And so why aren't we talking about that? So what we are trying to do, in addition to kind of social media, we want to be better partners to everyone doing this work, whether you're a member of my organization or not. And we want to create a foundation of information for policymakers. So I want Mayor Quinton Lucas to look at my data to recognize that you need to be talking about affordable housing every single day. Every time you're moving around, we need to be talking about that. If presidential candidates can talk about affordable housing on the national level, looking at ways for the federal government to do it, certainly our local government should be doing the same thing. And this is what we're trying to do. So we want to amplify what folks are already doing. We've made it very clear at KCHC that we are not seeking to recreate the wheel. We want the existing wheels to work better together. We are also collaborating with a whole lot of folks. That's how Tammy and I connected. Mutual folks recognize that we are trying to do the same thing, trying to save the world, and here we are. We want to elevate the work that folks are doing. We talked a little bit about data already. And then the other part that I think all of us need to be thinking about, especially during an election year, we need to be thinking better and more creatively about how do we advocate for all of this work. Because there's no way we can do this without policymakers standing behind us and creating some long-term legal opportunities to make sure that this work is sustainable. So this is what I've also learned in this new role is transparency is key. Everybody wants to know everything. So I'm not going to go through a whole lot of this, but I want to let you know what we're doing. So when I started, all my board said is, we wanted advanced health equity. And I go, I don't even know what that means. And they said, well, that's your job. You got to figure out what that means. So spent a lot of time talking with folks, meeting with community, sitting down with leaders. And this is sort of what we have come up with. So here's the left three columns are, I call our service lines. We've got a learning and action network, which we're going to talk about later today. We're actually going to create a learning network in this space later on this afternoon in my talk. We have partnered with Health Forward Foundation. The first iteration of this took place during COVID, where we worked with the entire regional health ecosystem to train folks about the racial bias that has infected healthcare, to tell them how we got to where we are. Because for y'all sitting in the room, you know that the disparate numbers that popped up during COVID and those remarkable Black and brown deaths that occurred at much higher rates than everybody else, we knew those numbers had been there for a long time, but it's only COVID that brought that to the fore. So what we want to do is we continue working on that. We've got action teams working on that. We are in the process now of co-designing a new learning and action network that's going to be focused on Black maternal health. Included in that is going to be race, ethnicity, and language data as well. Right now, not enough organizations are committed to collecting that data, which means we do not have enough data to show where disparities are occurring and what we should be doing to address them. We're also developing a unified care hub. This is essentially a fancy term for a closed loop referral system. So we are working with a local nonprofit community-based organization, Urban Neighborhood Initiative, and trying to develop a referral system that is going to connect clinical providers with community-based organizations to address social drivers of health and to address health-related social needs. Right now, we know that on the east side of Truce, there are food deserts, there are medical deserts. And so what we are trying to do is begin the process of laying the foundation for not only recognizing the need to address that situation, but then also to develop enough data that we can have conversations with insurance companies to say, you should be looking at value-based payments. Because right now our healthcare system is based on acute care. We are happy to take care of you when you break your arm, break your leg, get into a car accident. But the issue is, if you don't have a home to go to recuperate, if you don't have healthy food to eat, to stay healthy, that's a problem. And everybody needs to be a part of that discussion. So that's a long-term play. And then we've also talked about the aggregated health data, another fancy term. We're still trying to figure out what that looks like. We want to be, at KCHC, the repository for reliable, deployable data. So right now, that data that you saw up earlier, all of that needs to be made available to the entire community. So for instance, in Kansas City, Missouri, and I focused a lot on that because that's where I live, 64113 zip code has the highest life expectancy in Kansas City, Missouri. But if you go 5 miles east to 64128 on the east side, your life expectancy dropped 14 years. And so we can be shocked about that. I don't think enough people know about that. And if they did, they'd be disgusted and would declare that this is unacceptable and we need to do something about it. Or the fact that Black and brown women, regardless of your socioeconomic status, regardless of your insurance status, you are 3 times more likely to die of pregnancy-related issues, preventable pregnancy-related issues, than white women. And so that is another bit of information that everyone needs to understand. And so I think it motivates people to do more, because it can't just be the folks in this room who continually bang the drum, because you've got patients you're taking care of, you've got work that you're already doing. So other folks need to be in this boat, to use our ship analogy, to keep helping us row in the right direction. And then the other parts I put out there for my membership as we talk about sustained success. How do we continue engaging new partners? How do we continue working with folks to make sure they understand it? And then make sure our members are happy. It's like everything else. How do you make sure members are happy and feeling plugged in and engaged? This is our Unified Care Hub pilot. We just developed this slide, so I just figured I'd show it off. We're not going to go through that whole thing, but it kind of gives you a sense of the whole person care that we are seeking to provide our folks on the east side. Right now, we're working with 10 discrete neighborhoods that Urban Neighborhood Initiative works with, and so we think it's a nice, controlled, geographic location that's going to help us move forward. But you see the kind of services that we're hoping to provide for folks. Because as you all know, under the new CMS rules and CDC and Joint Commission, you have to screen for social drivers of health when they come in and when they're discharged. And there's a moral obligation now and a financial obligation to address those issues. And so if Dan Cranshaw is being discharged from St. Luke's and he tells you he doesn't have a home to go to, you've got to help him find a home. And so what we do know is that those clinical providers don't have the connections with the community-based organizations that an organization like mine will have. And so we want to create an interface that allows them to connect more seamlessly, and at the end of the day, the patient is at the center of that work, at the center of that service. Okay, so that's all right, that's chapter 1. So we're gonna take a deep breath. Any questions on KCHC? I talked a lot. Am I talking too fast? Are we okay? Is that a yes, I'm talking too fast? Oh, good. Okay. All right, so that's what we're doing at KCHC. I didn't want to spend a lot of time. Oh, yeah. Mariah Kranz is here. So we should, so I know, so people are laughing because it's Mariah, because we love Mariah. Mariah is also a brand new board member, so we are happy to have you here.
I just
You're on.
want to say, if anybody has any questions on how to modify your internal data tracking for REL data, the race, ethnicity, language, we did it as a CBO, modified it and meet the new OMB standards that'll be required starting in 2029 of anyone receiving CMS funding. Happy to talk about and share that success. And out of the land project we had with the REL data, we're the only group that actually was able to modify our data. So modify how we collect it. So if you have any questions, I'm happy to answer those.
Thank you, Mariah. Anything else? All right. So the Beehive. So what I wanted to talk about, so what you saw with KCHC is that we are collaborating around one particular issue, health equity. And so we continue to do that. Here, I want to talk a little bit about collaboration and action for one demographic. So during 2020, during a remarkably cold winter, Kansas City relented and opened up its convention center as a warming center for the unhoused. And so what it did was it raised the issue of the fact that, and it was packed to capacity. And civic leaders were surprised that there are that many unhoused folks in Kansas City, Missouri. I know you're all shaking your head going, really? Go figure. And so that started a long-term conversation, sadly not with policymakers, but with folks who were working with the unhoused to say, what can we do to make this sort of engagement sustainable? So from that, Care Beyond the Boulevard, Nourish Care Beyond the Boulevard provides medical care for the unhoused on the street, meets them where they are to provide medical care. Nourish KC provides food and clothing for folks. And the Greater Kansas City Coalition to End Homelessness is also part of this. So these three organizations got together, recognizing that their policymakers were not going to follow up on this great opportunity, and decided that they were going to collaborate to figure out a way to take better care of the unhoused population. They recognized that transportation was an issue. They recognized there was never going to be enough transitional housing available, but they wanted to do what they could. So what they've done is they created a space at 8th and Paseo. I'm not sure how many folks are from Kansas City, but it's in the community where folks are already present. They partnered with the Downtown Council, which is a private organization that owns some property down there, and said, will you help us pull this together? So those three organizations took over a building. On the ground floor is where folks were provided food, and they can go upstairs to receive medical care, behavioral health care, and there are offices where visiting staff can come in and cycle through and take care of those folks. And so what is remarkable about that is that it is a nonprofit, private partnership that is collaborated, and you've got these nonprofits also collaborating to say, how do we solve a problem that is so clearly evident? And so when you think about the work that they've done, and I just pulled this off the website. That's a lot of work. That's a lot of work. And if you spend any time going over there chatting with them, it is full all the time. But it's a controlled chaos. You've got staff moving around and engaging with folks. It's a safe space where folks are able to get their needs met. And one of the things that you all alluded to at the beginning is this idea of we need to respect community. And that's the other part of this work that's really engaging and encouraging, is that we are respecting folks where they are and just recognizing that there's some needs that you might not be able to meet, and we're going to help you meet those. So it's been wildly successful. I've been really impressed with what they've been able to do. But it shows you the comprehensive whole person care that they're providing. And what this work does is demonstrate to policymakers that this is solvable. It may not be a permanent solution, given what they're doing, but we need policymakers to create the permanent solution. So being able to witness how volunteers working with small staffs and smaller resources can begin solving this problem. Imagine if there's an ordinance that says, out of your general obligation bonds, this is what's going to be drawn down, as opposed to more funding for streetcars or debating whether we need to put a cover over Arrowhead, which wouldn't be the worst thing, don't get me wrong, but that should not be our highest priority. And here are their community partners. And this gives you a sense of sort of how comprehensive their work is as well. I think that, in my mind, knowing that you've got these folks as invested in the process as those three founding organizations is another powerful sign about what collaboration can do and what we all should be thinking about. And I hope it's something that as you ponder returning to your communities, to look around the folks around your own tables and asking who's not there and who possibly should be there, asking who else is sort of rowing in the same direction you are, addressing some of those issues, or if there are some complementary issues that y'all should be working on together. I think that's worth thinking about as well. Okay, that's the Beehive. Questions? That's chapter 2. Because I'm talking really fast. Am I okay back there, Tammy? Okay. Yes?
Do you have any specific anecdotal information about your Lotus House there and how that comes into play with anything?
Okay.
I was asking if you have any anecdotal data about how folks are working with your Lotus House in Kansas City. We do have one in Topeka, and
Okay.
looking at ways to integrate them more into the conversation. And so I was excited to hear if you've got anything about that.
Yeah, no, it's a good question. I do know of Lotus House. I have not connected with them yet. And so I think and it's a great question. So, and I will make sure to write that down. So what I do is when I do these talks, you suddenly realize there are a lot of folks out there that I've not connected with. Oh, you have a follow-up? Go ahead. Okay. Anything else? All right. Oh, yes.
Darn quick, don't I? And I'm wondering if there might be another, let me see. Replication is what I have in my mind. And are you open to expanding to other states, or are you all still nascent in?
For KCHC?
Well, it wouldn't be KCHC.
Okay. Oh, you're talking about the Beehive.
The whole model, your collaborative.
Oh, it's a good question. Oh, but those are really good questions. All of a sudden, everybody wakes up. It's a good question, and it's popped up. And I'll tell you, when we jump into the Learning and Action Network, that popped up. We did a presentation a couple of weeks ago, and folks talked about that. Haven't ruled it out, and I've shared with folks. So I've been in this role for 17 months. It'll be 18 months on Friday. So I do believe that there are some opportunities to sort of replicate what we do. And frankly, I also think that in all of your communities, there's an opportunity to do that. That I don't think it needs to be nationalized or you need to pull from a chain. I think that, and I'm going to give away my closing takeaway, which is I think if there's a willingness to take ownership of the solution, meaning that you don't have to say, I'm going to solve it, but it is to say, if there is an unhoused problem, for instance, in Kansas City, and we saw that during the warming crisis or the cold snap, and the warming space provided some opportunity to reflect on the necessity to address that. And you've got some leaders, those three organizations said, we'll handle this, and then invited other folks to be a part of that. And so it makes me think of Harry Truman used to say, it's amazing what you can get accomplished if nobody's looking for credit. And so I think in folks' communities, if you're willing to say, I will convene a community table to talk about the unhoused, or to talk about behavioral health in teenagers, or to talk about, and we talked about this a little bit at dinner, about the LGBTQ community feeling under siege, especially the youth feeling under siege all the time. How do we take care of those folks? And then say, let's figure it out. Knowing that it may not be permanent, knowing that it might not be perfect, but it's a start. So, but I'm going to think on that though. I might be able to get a license, and that's a whole other thing. Thank you though. I just turned cynical and corporate. Yes.
So really piggybacking off of what you just kind of said and that replication method, many here in the room from small communities. And so thinking about how we can replicate who we should, maybe you could help us, who we should invite to the table when we're trying to think in our small communities of 2,000 to 5,000 folk, who are some diverse members that we can invite to the hospital,
Yep.
invite to the healthcare system, so that we are making it a community issue when we have identified social drivers of health in our area, and what do we do with it so that it is not just a hospital feel.
Yep.
We're asking these questions, doing nothing with who can we invite to the table. So I do think that would be actionable items
Yep.
to take away for most of us today. Thank you.
No, such a great point, and I love that. So that is a perfect segue into chapter 3. Thrive Allen, Kansas City. Is anybody here from Thrive Allen? No? Then I can talk like an expert then. So Thrive Allen started in, I want to make sure I got the right date, started in 2005. This was started by their Health Advisory Board committee. And so what they recognized, the issue they spotted was, number one, it was unhealthy. People were not getting dental care. They were not getting primary care. They weren't getting behavioral health care. They were also shrinking as a community because people were leaving and they didn't feel like there was any viable reason to remain. And so a group of folks through the advisory committee got together and started thinking about what can we do to solve this problem. And that's when they started pulling community leaders as well as business leaders and hospital folks together to talk about what can we do to make this thing happen. And then you get a sense of how this all shook out. The key part, I think, and as I look at this from the outside looking in, is the planning grant that the Reach Foundation shared with them allowed them to really jumpstart their work. Now, having said that, and this goes to your point, I do think that it is important to have an understanding in your own community about what you're trying to get solved, because there are a number, philanthropy is interested in this. They're profoundly interested in this, but philanthropy, as opposed to funding individual projects, is now looking for systems change. They just don't want to give it to Dan Cranshaw entity. They want to say, a whole county-wide region. So that's why Reach was fully invested in this. Patterson Foundation does this as well. So I pulled out some things from their website. So what they did was, oh, well, I can tell you what they did. Here's what they're doing. So what they did is they pulled together and continued having conversations among themselves. They pulled in community, which was a key part of the work, which is to talk about what exactly do you want from your living space? What is it that you want from your community? So there are little things that matter. One small town talked about the fact that we don't have, our cell service is so bad we have to go to the cemetery and hang out because that's the only place we can get coverage. And so then suddenly that is a conversation, because getting a cell tower is not terrifically expensive, number one. It's a value add. And if you tell businesses that you're going to increase purchasing, you're going to increase power, but also it is cell service is part of telehealth, which has become kind of the new focus as well. So just little things like that. I talked with the executive director a couple of weeks ago in preparation for this and talked about what are the other things that sort of got you motivated. But it was having these community sessions and people would say, just the fact that my grass, the grass is overrun on the highway running by our town just makes us feel like we're forgotten and nobody cares about us. And so getting just a little bit of resources to mow that grass down by the highway, getting people to feel a little more pride. But then it's essentially a part of civic infrastructure, that people feel that their voice matters, they're going to start speaking up, they're going to be more engaged about their community and what's happening. And I think that's a key part of what we're all trying to do. How do we center the patient and community in everything that we do? So I think that's part of it. I also think there are civic leaders who are interested in this. All of these small, I shouldn't say all of these, a lot of small communities have folks with more resources than they would otherwise let on who are willing to be engaged in that. And it doesn't have to be just money resources. Sometimes it's just time. Who's going to spend the time knocking door to door and say, how are you doing? What's not a formal needs assessment. Sometimes it's an informal needs assessment. Tell us what's going on in your house. Tell us what's happening with you. So this gives you a sense of everything that they've done. So they, in addition to these programs and being fully invested, every year they go to every city in Allen County and have a listening session with the community to say, how are things going? How are we doing? And what would you like us to do the next year? And it's labor intensive. They got a pretty small staff, but it matters, and folks look for that. And so I think that answers your question, that it opens up an opportunity where it does not, again, and it ties into your question as well, where it does not have to be kind of this national, it's not like United Way where we all have to be part of a national organization. This can be in our town, in our community, this is how we're going to roll. Now, it just means someone's got to be willing to do the convening. Someone's got to be willing to send the email out and get the listserv. Someone's going to have to take the phone call because somebody got left off the first time. Because that's right, I heard that, yep. Okay, so that's pretty exciting. So any questions on Thrive Allen County? Oh, which question? A Zoom question. Oh, you want here?
Sorry, Casey, I'm coming.
Oh, that works.
All right, the question on Zoom is, we are a health IT vendor looking to solve the data interoperability challenges in exchanging and connecting and collaborating systems we talked about. How would you advise us to move forward in using our solution to the next level, improving organizations' infrastructure, and in order to solve the current health equity issues?
They were typing. So that is a great question. And Tammy and I were talking about this last night. So we are part of Civitas, which is a national organization of these regional health improvement organizations, and interoperability. And just so folks have a sense of, because it's a horrible phrase, you all probably know this, it took me a while to get up to speed, but interoperability has to do with just about every hospital system has its own electronic health record. Community-based organizations will have their own electronic database, and then there'll be some other databases around there. And so, and right now, not all of them talk to each other. And so that has been an issue. Federal government is looking at this. There are some regulations called FHIR that are mandating some interoperability, making sure that they talk to each other. Because as the oldest person in the room, I can remember when Windows wouldn't talk to Apple, and it's all worked out just fine. Because in my mind, I think we have a space station that we have created with the Russians. Surely we can figure out how to get these systems to talk to each other. So I do think, so I don't know if I'm answering the question, if they zoom back and I'm not answering, but I think it's going to take a long time to get to that. We're chipping away at that. We do need to keep talking about it, and I love the fact that they've asked the question, but we need to put pressure on hospitals and systems who can afford to update their systems in a significant way, and to support community-based organizations better. Yes.
I just want to add to that I'm from Lawrence, or I work in Lawrence, Douglas County, and we use something called MyRC.
Okay.
Johnson County also uses it. And what that does is allow us, our agencies, to connect and see information on the same individual that we all share. So our police department, our hospitals, our mental health facilities, our shelter, we can all talk to each other. Our fire and medical, and I'm with the city Homeless Solutions Division, so we can all kind of see where our people are and what they're receiving. So there is some that
It's working.
some systems that are working that way
And which
already.
town is that? Which community?
Lawrence, Kansas.
Okay. Okay, excellent. All right, so we are going to talk about the regional collaborative effort to address health equity. So the Learning and Action Network, we talked a little bit about this before. This is what KCHC is doing in partnership with Health Forward. In 2020, during COVID, there was a recognition that all of those disparities that we witnessed had been around for a long time, and it put us on notice that people didn't understand how we got here. So the idea was, let's create a regional learning and action network that would challenge folks, that would empower folks with knowledge, and then challenge them to do something about the health disparities that exist in healthcare. It gives you a sense of what we're doing, what we're trying to do. So it started with a co-design phase that we did. KCHC was part of that, Health Forward was part of that, IHI, Institute for Health Improvement, which is an international quality improvement organization. We got together to think about what is a curriculum that the health ecosystem needs to learn about why racism exists in healthcare. Those are the three organizations. Here are the folks we worked with. Those are the folks who are sitting around the table. And so over the course, during COVID, we conducted webinars once a month talking about here's how we got here. Very comprehensive curriculum, allowed folks to ask questions just like we're doing here, but to really have a better understanding about some of the silliness that, I call it silliness, that happens in healthcare. I don't know if anybody's read Dr. Uche Blackstock's book yet, Legacy, Physician Reckons with Racism in Medicine. It's pretty powerful. Black woman, mom graduated from Harvard Medical School. She and her twin sister graduated from Harvard Medical School, practiced medicine for a long time, but was really shocked at the amount of biased information that she received as a student and didn't appreciate how biased it was until after she got out. So the idea that Black folks have higher thresholds for pain, which is why they won't get medication, which is why Black women are generally not believed when they talk about the fact that they're in pain. So little things like that. So having folks appreciate what that means and how it has impacted their work in healthcare was a key part of this. So you get a sense of all the different kinds of folks who are sitting around the table. CBOs, hospitals, we had some employers who were part of this discussion as well. And the idea was to level set an understanding about where we are and how we got here. And those are the values that we came up with. So during the co-design phase, which takes forever. So here's what I've also learned, and I'm going to admit that I'm a cynical attorney. So I love the phrase moving at the speed of trust until you start moving at the speed of trust. You're like, oh my gosh, it's taking forever. And that's okay. I've gotten used to that. So what we've learned though is over the course of time, these values were very important for the entire group. Not only did it create a safe space, but also created a brave space. Because we wanted folks to be able to lean in, to recognize that there are some things that I'm just not capable of doing, or at this point, or I'm restricted because this is how I've been trained, this is how I've been brought up. I brought my own biases to the table. For me, when I first joined, and I joined at the kind of the tail end of Land 1.0, I think it's that last one that really is something that we all should be thinking about, is this idea that even though we are operating within this current system, we should all be dreaming and hoping for a better one, and confident that if we keep leaning into that, we can make that happen. And then we develop goals that are consistent Everybody gets them. Everybody signed off on them when they first got here. Goal 1 is working with our CEOs. There's a recognition that when you think about some of the equity work that we do, that there are frontline folks who are doing all the work, all the ground level work, but we know that in order for the system to change, CEOs have to be involved. So in order to participate in the land, CEOs have to sign an attestation that they will make health equity a priority. They will seek to diversify their board, because we're not looking for quotas. They will seek to diversify their frontline clinical staff. Goal 2, we work with our action teams, and I'll talk a little bit about that in a minute, where we want land participants to grow. We want them to grow as individuals, to learn how to work in this space and be successful, but we also want their organizations to do the same. Goal 3, rel data. In the clinical piece, we want to increase the quality of healthcare. And that's actually how we all want to be thinking about this. What I've told folks, especially as we are operating in our 2 red states where DEI is against the law, these aren't DEI practices. This is quality improvement. This is making sure that everybody who is taken care of in the hospital system is taken care of equitably. And then goal 4 is kind of building a movement. We want to make sure that all this work that we're doing and leaning into is sustainable and it lasts. And that 10 years down the line, when we're all talking about the changes that have happened in the system, that the land is still moving forward and operating and people get it. I mean, that's really what we want to be thinking about. Do people get it? And that's the roadmap. That's what we did. And that's sort of long-term. I know Mariah was part of that too. It was a lot of work. And so we leaned in. And so the design part was key because it ensures that we are hitting the topics that folks want to hear about, but we also identify the stuff that people need to hear about. We worked with community. We have centered lived experience in this work. And so not only do we bring in community members as part of the LAN, which is what we call the Learning and Action Network, the LAN fam, we also pay them for their expertise because they've been brought in as experts and we want to pay them like everybody else. So we talked a little bit about the learning phase already, and that took place over the course of a little over a year where we learned about some of these key concepts about bias, issues related to that. The key thing that's pretty exciting and unique to our effort is the action phase. And so after the learning phase was over, we invited teams from organizations throughout the region to apply to be a part of the action community. These folks came with plans to operationalize health equity in their own organizations. So for instance, Wyandotte County Health Department drafted an ordinance declaring racism a public health crisis. They conducted listening sessions, met with folks around the community, and came up with 4 kind of discrete bullets about how we're going to move forward to make that happen. They haven't gotten it passed yet because, of course, they ran into politics, but they're working on it, and it's pretty exciting. We know that University of Kansas Hospital, when they disaggregated their data by race and ethnicity, found that their heart patients, their Black heart patients, were suffering worse outcomes than their white ones. And so they have developed a community health worker program to work with those patients to improve their health outcomes. Now, for community health workers in the room, we know that when you start hiring community health workers to be your employees, they're not community health workers anymore, they're just employees, but that's a whole other story. The fact is that they're trying. So there are so that we've got 15 organizations who are working on operationalizing health equity in their own organizations, still operating, still in action, still sustaining the work, and that's pretty exciting. We're pretty fired up about that. We're not going to go through that, I promise. That is the driver diagram that allowed us to stay focused on what we're trying to get accomplished. So when we thought about the goals at the beginning of the process, identified kind of the big goal and then broke it down into different areas, knowing what had to be done and having a roadmap. And I think that was key for us to be successful. And so I think we're almost right on time. All right, so that's my, are we good, Tammy? Okay, so all right, so that is chapter 3, right? No, that's chapter 4. Chapter 4. All right, any questions right there? Because we're going to move into an exercise phase in a minute. Yes, sir.
I have two questions, if I could, please. This may relate to your data aggregation project or that aspect of your project. What difference would it make from your perspective if patients had personal health records, complete longitudinal health records, as was in fact mandated by the Cures Act in 2016, but still hasn't happened? What difference would it make in all the issues that you're concerned with if that were possible today?
Well, it's a good question. I think that from our perspective, we want to empower patients to have some control over their care. My concern, in fact, we talked about this last night, Tammy, the issue I have with that is I don't know that we have done enough to educate the community about how important that information is and what they should be doing with it, what they can be doing with it. So I don't know. I think that it depends. It depends on if that person kind of knows how powerful that information is. But the other issue in my mind is to recognize that even if you've got copies of your own personal health information, other folks are still going to have it. That there's a whole system out there. The price of admission for all of our healthcare is that you've got to cough up some of that information. And I just don't know how, because some of the discussion has been, you get to pull it out of the system. You don't have to acquiesce to any of that anymore. So that doesn't answer your question just because I think that it really depends.
My other question has to do with clinical research. One of the other discoveries, as I understand it, from the pandemic, is not only is care very sparse and not properly distributed around the country, but clinical research also provides information for research.
Yes.
And yet it also does not come from the entire population of the United States. And there is a movement nowadays to combine research and clinical care. In other words, to have individual doctors, primary care docs, for example, actually include their patients in clinical research.
Yep.
Perhaps not rigorous trials, but at least observational research. And that actually could provide a new source of income for the doctors and for the patients. Is that something that's on your radar?
So that is so interesting. It just popped up on my radar because I got 2 calls last week from folks. So there are a couple of organizations that are working on increasing diversity of clinical trials. And under the CARES Act, I think there's interest in that, and I think there's been pressure. Big Pharma, Genentech has got a big presence in Kansas City, and they've talked about this as well. So the issue is, and this goes back to your first question, is the degree to which folks are knowledgeably consenting to that participation. Do they understand that you can ask for more than that Visa gift card that they're going to give you? And do you know that your information is going to go kind of up the chute and is going to be aggregated with a whole bunch of other folks? So I think it's good opportunity. I think the question is, have we empowered our community? Have we centered lived experience enough in our community members so that they know what they're acquiescing to? Any other questions?
Dan, I have a question.
Yes. Oh, yes.
So back to the Thrive Allen County example, and this kind of piggybacks on some other questions we've had. So we have a lot of rural folks in the room. And we know that Thrive Allen County, it's not the only community health group or community health coalition that exists in the state. And we know that we don't do any of this work in a vacuum. So how do you suggest for the folks in the room who are interested in this community table, these community conversations, how do you suggest that they connect to the work and the groups already happening?
So, well, it sounds like you need to be working with KFMC a lot too, right? Is that what an alley-oop was? That was pretty good. So I think, so there are a couple of ways, and I meant to add a slide at the end that kind of talked about the other organizations in town, but there is the Rural Care Hub online. I think, so There are resources there. I think reaching out to some of these philanthropies that are focused on rural care, the Patterson Family Foundation, they just named a new executive director. I would recommend all of you drop her a congratulatory note and let her know what's going on. Be pretty cutthroat about it. And I think talk amongst yourselves. I will tell you, when I did research in preparation for this, my concern was I shouldn't say concern. I think there's an opportunity. I don't know that there are as many sort of big centralized organizations as there could be, or at least they're not organized enough to have websites. So when I chatted with Thrive Allen, Kansas City CEO, she wasn't aware that there were a lot of peers around. I think they're trying to get a Kansas statewide organization going. But it seems to me right in this room is an opportunity to start thinking about how do you start pulling those network nodes together. And if other folks have, and I don't want to presume, because y'all know I'm a city boy, so if I'm wrong, feel free to call me out.
Thanks. And I would encourage people too to connect with their local health departments. A lot of community health coalitions are built from funding that local health departments receive, and that is how Thrive started. So.
Good point. Good point.
Thank you. I'm Elaine Johannes. I'm at Kansas State University Research Extension. We're across the whole state. We have professionals in all 105 counties. You may have heard about our announcement with the University of Kansas Health Systems. We have collaborations going on right now. And then just last week, the Kansas Health Foundation has announced funding and support for food insecurity responses through K-State Research Extension. So we are a statewide system. We work across all universities across the state. We are also national. So K-State is part of the land grant system, and every state in the United States has land grants that are working on health care, health access, literacy, and opportunity. So good that you shouted out rural.
Excellent. Thank you for that. Okay, so we are going to move into our exercise. So we are going to create a little mini learning community right here. So I've got a quote from Ibram Kendi that talks about definitions, and is going to kind of give you a sense of how we in the land got to where we got to, in terms of we started from scratch, we built up a structure, built up a common language, and built up common goals in order to move ahead on that project. And it's one of the reasons why it's been successful. So we are going to pull together, I've got 12 cards, and we are going to pull together 12 tables. And if you could coalesce yourself around those tables, I've got what we're going to call equity definitions. I'm going to give you a word, and the table is going to talk amongst themselves for 10 minutes, define that word, and then we're going to report out at the end. I know, I'm going to keep it. We might not be able to report all of it out. I saw you look at that watch, I know. So we're going to do a little bit of that. We'll report out as much as we can, and then we'll kind of close out. How does that sound? So if we could, I think we've got 1, 2, 3, 4, 5, 10, and then 2 in the back. So we'll do the front rows of folks, and if you coalesce around these, how about we just do the two front rows, coalesce around those tables, grab your chair. I'm going to drop off a card. You guys are going to come up with definitions, and then we're going to talk about those definitions. That make sense? Okay, we're going to start reporting out, folks. So I want to be mindful because Tammy told me I have to stay on time. I do what Tammy tells me. So we're going to start with anti-racism.
Where's that hard one? All right, we came up with actively identifying and opposing racism, actively changing policies and behaviors to create cultures that lack bias, both conscious and unconscious.
Good, thank you for that. All right, you ready? We can go over there. All right, our next is health disparities.
That wasn't easy.
The concept of different health outcomes based on some individuals not having access to health care due to race, gender, address.
All golf clap. That's good. That was good. All right, what do we have here? Race equity, race equity.
All right. So we had a lot of discussion about this. I don't think we actually had a whole sentence. We just sort of talked. But essentially, race equity would be the ability to achieve your highest outcome regardless of your race and be given the tools that are appropriate for you to achieve that outcome.
That's good. Well done. All right, what do we have here? Race.
Our definition for race, we went through and tried to simplify it as much as possible, but social construct for grouping individuals.
That's good. Round of applause. Get ready. Who's talking?
We have equity, and our definition is provision of resources, support, and cultural inclusion in order to provide the opportunity to achieve health, mental health, economic, and community success individually.
Nice, very nice. All right. Round of applause. You guys are so stingy with the applause. Oh, you do a golf clap too. That's true too. All right, health equity.
We had great conversation around this, and everybody contributed from different angles. You know, when you're looking at the actual definition, it says health, the state of being free from illness or injury, but that also involves physical, mental, and social well-being. And then there's equity, and we were talking about the quality being, you know, the actual definition is the quality of being fair and impartial. However, you know, everybody brought different pieces to the room or to the conversation about that. And, you know, when you're working in communities, maybe DEI might be kind of a deterrent for people to talk about that. So there was somebody who said that they changed the wording to health equity justice, which we thought was really good. And then we discussed the differences between equality versus equity. And somebody had also mentioned, you know, a great statement of equal outcomes regardless of their opportunity.
Golf clap. That's good. That's good. Thank you. Oh, did I? You're good. You sure? I'm stepping on your toes. I'm sorry. Culturally responsive.
So we had a collective definitions too, and so for culturally responsive, we put any program practice helping celebrate their backgrounds. You know, what would our action be to include everyone? Actively listening, changing our own views. Not everybody fits in a box. Inclusivity and accommodations. Different communities, different cultures. Looking through a different lens, knowing your privilege, and how can we help provide services.
Good. That's good. Thank you for that. Nicely done. All right, racism.
We have making judgment or treating someone differently because of their race, and then also generational misconceptions on learned behaviors that may or may not be intentional.
Good work. You guys are killing it. Oh, that's probably not a good affirmative word. Oh, here's an affirmative word, white supremacy. Probably not supposed to joke about that, sorry.
Yeah, we kind of struggled with this one, but we came up with a feeling of being better than others because of known or unknown biases that result in others feeling invisible.
Oh, that's good. That's good, thank you. Golf clap. All right, privilege.
We spoke about it a lot, but really we narrowed it down to a small definition of leveraging advantages for benefit, whether that would be positive or negative.
That's good. That's good. Thank you. Well done. All right, what do we have here? We have implicit bias.
We had discussed that implicit bias is the unconscious awareness of the ability to recognize stereotypes and the attitudes towards the underdeserved communities. Folks, but we could go on. We did discuss a ton of other things. Does anybody else have anything to add?
That's good. That's good. Golf clap. Here we go. All right. And closing us out is microaggression.
So small, subtle abuses, unintentional or intentional discrimination against a marginalized group. For example, I don't see color, where were you born, and maybe calling someone by the name that's not preferred.
Nicely done. All right. Round of applause. Give yourself a round of applause. That was really good. So what I'll do is you will have these slides. What we have is a collection of definitions. Oh, see, I was supposed to give you all of that. Look at that. I'm terrible at this. I'm not going to read those. You can take a look at those. You're going to get these in the slides as well, Tammy tells me. So it kind of gives you a sense, and you'll have the source of where we got those definitions. As you can tell, so what is nice about this exercise is you get a sense of it. There's a level of work involved that all of you may know each other a little bit, but the group dynamic changes when you get down to looking at some really hard words, trying to identify who's going to speak, who's not going to speak, who wants to participate, who doesn't. And so, but it does sort of help you kind of get a sense of what it takes to lean into some of this work. So I've got a project manager help put these slides together because I don't know how to do that. It literally takes me weeks on end to put slides together. How we have time? I think we're right there. Oh, well, 6 minutes. All right. Well, you're going to get these on the deck anyway. All right. So let me, I'm going to go all the way to the end. And so you have my contact information. So I think we covered a lot. It would be my hope. There we go. Feel free to contact me. We are online. We're refreshing the website, but you can track me down anytime there. I am happy to be of service to any of you. I do think we've got some great information that came from the group, actually, in terms of where to connect. Health departments are key. I think that's important. Land grant institutions hadn't thought about that. I think that's key. I think thinking about how you create your own networks and systems that will entice investment, I think is important. But at the key to all of this is centering the community that you're trying to serve. I think that to me is essential, that we all have this sense of what's going to work or what should happen or what we should be doing. But we do need to be asking those folks who live in that community, what do you need? How can we help? So with that, I want to thank you for your time. I want to thank you for the questions. I want to thank you for the engagement. It's been an honor being here, and I look forward to seeing you the next time. Bye.